let's talk a little bit about the Pacific trial. We've been waiting for a very long time to deliver a consolidative therapy post-concurrent chemoradiation that translates into an overall survival advantage. This has been attempted multiple times. We've had consolidation chemotherapy being looked at. That was negative. We've had consolidation targeted therapy looked at. That was negative. So this has been a welcome change with the Pacific, and this was a very straightforward design. Patients with stage 3 unresectable lung cancer who had received concurrent chemoradiation were randomized 2-to-1 to durvalumab, a PD-L1 drug, an immunotherapy drug, versus placebo, and keeping in mind that placebo was the standard of care at the time that this trial was designed and the therapy started to be delivered. Durvalumab was given every 2 weeks for up to a year, and we saw initially in a New England Journal publication last year that there was huge difference in progression-free survival. You could drive Mack truck through those curves. We were very encouraged by what we saw in the PFS, but we were all kind of waiting around to see the OS advantage, and we weren't able to get that until recently. And we saw an OS advantage more recently 6 months ago in the New England Journal of Medicine paper, and also presented at World Lung in Toronto, showing a meaningful difference in median overall survival, 12-month overall survival difference, 24-month overall survival difference. So I think this has been practice changing. There's been importantly a look at key subgroups of patients in this trial that may have benefited more. And interestingly, when you look at PD-L1, there was a group of patients that did not benefit, and that was the PD-L1 less than 1%. And this led to Europe not approving immunotherapy for patients post-concurrent chemoradiation if the PD-L1 was less than 1%. And the U.S. and the FDA approved it for all patients. Whether PD-L1 really makes a difference, and Sam, whether we test in stage 3, I think, but whether we use that information is really up for debate. I think for most of us, we end up giving immunotherapy for most patients. I think the other interesting key subgroups were, and it will layer into a question about the timing of scans, but if you were able to give the immunotherapy, the durvalumab, within 14 days after the completion of radiation, those are the patients that did better. And that's a little bit of a concern because we thought if we gave immunotherapy right after radiation, there would be a pneumonitis concern. And we didn't see that in the trial. So it's really altered how we deliver. Usually we give concurrent chemoradiation, we do a scan, and then we follow these patients. Now, if you want to go by the data, maybe there's an opportunity to give immunotherapy within 14 days without even doing a scan and getting them going on therapy. This is clearly, you have up to 42 days to do it. The other key subgroup that we looked at was EGFR mutated lung cancer. They were allowed in the trial. This was a group that did not derive a benefit in overall survival, and we'll talk about EGFR in the next case. Finally, if you look at toxicity, pretty well tolerated. I think we were anticipating seeing pneumonitis, a higher incidence of pneumonitis, and we didn't see this. So clearly practice changing. Isabel, any thoughts on this? Has this clearly changed your practice, I assume?
I think it has changed my practice for some patients, but it's definitely a shared decision-making process that happens. I review the data with the patient. I talk about, positives versus negatives versus going on on immunotherapy. And I also let them know that it's not a binding contract. While it does call for durvalumab every 2 weeks for a year, sometimes patients, I've found that patients have still gained a benefit if they've ended up, with some toxicity and had to come off after 6 months or even less.
Well, the question is, again, do we need a year or not? Can it be 6 months? I don't think we know. Anju, do you talk to patients about our radiation oncologists get very much involved, and I don't know if these are one-offs or not, talking about immunotherapy to patients post-concurrent chemoradiation.
Well, so I have the fortune of working in a multidisciplinary clinic, and so we have patients seeing our medical oncologist and myself at the same time, and I love to get involved with these discussions, and I think that this trial in particular did a great job of making sure that there was a good QA on the radiation plans, ensuring that those plans met those criteria in terms of the V20 of what I was talking about a little bit earlier, and I think that that, we all kind of get involved in terms of the decision making about saying, we think or we anticipate that, in your case, this may be followed by immunotherapy as a maintenance or consolidation treatment. And we also, often discuss, the timing of post-treatment imaging as well.
Yeah, okay. Great discussion. One case down.
Could I ask a question to the group?
Yes.
So PD-L1 testing is relatively easy to perform. It's immunohistochemistry. We can get it back within 24, 48 hours. Even though it may not be indicated, is it useful information to have if you have a patient with an 80% TPS versus a 5% or 2%?
I mean, I was giving you a hard time on the prior PD-L1 question. We tested on every stage 3 patient, and I think the question for me is the issue for me is it may help me frame expectations on whether the drug will work or not, or how well it will work. If it's greater than 80%, I do tell patients there's a likelihood that this drug will further shrink your tumor. We don't know this from the data, by the way. This is the data-free zone, but if you look at the data, patients who had a higher PD-L1 had a more meaningful improvement in overall survival. The hazard ratios get smaller and smaller based on the PD-L1 cutoff. So for an 80%, I have a little more confidence. For the less than 1%, this is, I'm a little more cautious in how quickly I follow them and surveil them, whether the drug will work or not. But it's still approved. So I think it's very meaningful. Isabel, I don't know if you have any comments as a medical oncologist.
No, I think you bring a great point, Sam, and I echo Ben's thoughts. I think I use it to guide my discussion with the patients and use it as an education point. So patients that are unsure about what decision to make and don't really know which way to go, I don't really use it to steer them, but I use it to sort of explain to them what their expectations may or may not be with this result. And I've found it to be very helpful, actually.